So before we begin today with the presentation, I'd like to thank a number of people who have contributed to this study. But first of all, thank you to Perfusion.com for having given me the chance to speak today. I would like to thank our manager, George Justison. As you all know, he's been a big proponent of GDP, and he has been the inspiration behind our team's continuation of this effort into new arenas. So today, that arena is going to be the brain. I would also like to thank our very innovative and progressive aortic surgeon, Dr. Reese. He's just an absolute pleasure to work with and is always working on new techniques. So before we get into the interesting stuff, which is the study itself, we should take some time to review previously established and current cerebral protection strategies, including hypothermic circulatory arrest alone, and then adjunctive strategies such as RCP and ACP. We can also spend a little bit of time on oximetry and EEG. So the brain is very metabolic. Although it only accounts for 2% of our total body weight, at rest, it is responsible for 20% of the body's total oxygen consumption. It has a metabolic rate that is 7.5 times that of other systemic non-neuronal tissues. And then it also receives 15 to 20% of the cardiac output. Now, the brain is also still very metabolic even at hypothermia. So if we look here at 8 degrees, it still retains 11% of its baseline metabolism at normothermia. At 28 degrees, which is where we perform our hemiarches, we are still at 50% of its normothermic metabolism. So as you are all very familiar with, the consequences of inadequate protection, tissue ischemia and neuronal death can lead to temporary or permanent neurological deficits. So it is our goal to try to prevent and avoid these completely if possible. This timeline shows the progression of aortic surgery cerebral protection strategies all the way back from 1955, which the first aortic arch excision was described. That was done under normothermia with various pumps going to the carotid and subclavian arteries. And This early technique was produced unsatisfactory results, and at that same time, people started getting interested in using profound and deep hypothermic circulatory arrest, so it fell out of favor. Now, just one thing to note with this timeline, although selective antegrade cerebral perfusion was described as early as 1957, it of course was not a common practice until much later. In 1980, we see the emergence of retrograde cerebral perfusion primarily as a treatment for massive air embolism, so it has not yet been necessarily added as a common adjunctive strategy for cerebral protection. In 1986, we see deep hypothermic circulatory arrest being combined with ACP. We see RCP emerging more often in the literature in the 1990s. And then in the 1990s to approximately 2004, there is a number of studies that start examining the pros and cons of RCP and ACP, trying to figure out, hey, which technique should we really be using? And then approximately 2004 and onwards, we see kind of the emergence of two primary techniques in contemporary practice. We see moderate hypothermia coupled with ACP, and then there are also some centers still using lower temperatures coupled with RCP. This table shows the relative advantages and disadvantages of each strategy. Proponents of each strategy will pick out certain advantages when designing their technique. Now, some of this is surgically driven, so if your surgeon has used the technique and was taught that way, they're likely to incorporate it into your practice. But from a perfusion standpoint, there are a number of advantages associated with each technique. So for example, with hypothermic circulatory arrest alone, without any adjunctive strategies, you get the best exposure. With retrograde cerebral perfusion, you perhaps get the best homogeneous cooling and embolic and metabolic waste washout. And then with antegrade cerebral perfusion, those who use it will say, hey, we can use moderate hypothermia with this. We can extend our safer restoration, and we can reduce our bypass time. We don't have to cool as far, and we don't have to rewarm from that low cooling temperature. There are a number of disadvantages associated with each technique. We won't go through all of them, but you guys are very familiar with the fact that using deep and profound hypothermia results in coagulopathy, inflammation, and multi-system organ dysfunction. Retrograde cerebral perfusion may not meet the metabolic demands of the brain, and in some cases may be restricted by the venous anatomy. Antegrade cerebral perfusion, potentially requires more skill from the surgeon, and if you're using only one-sided antegrade cerebral perfusion, you could be limited on the left. NIRS. So cerebral oximetry using near-infrared spectroscopy is, I would assume, a very common practice these days. The way it works is it penetrates the tissues and is absorbed by chromophores such as hemoglobin. Most of the manufacturers, they say that they assume about a 70-30 split. So this technology is probably capturing about 70% venous saturation and then 30% arterial saturation. So when they use that split to report their oxygen saturation. We know that extended durations below specific thresholds, so if you're below less than 60% or you see more than a 20% decrease in your baseline regional saturations, or you see more than a 10% differential between your right and your left, is associated with poor outcomes. If you guys read the last issue of JEC, there was an article actually by a number of Russian authors that compared moderate hypothermia coupled with ACP against deep hypothermic circulatory arrest, and one of their results was that the higher degree of regional saturation decrease led to increase in neurological complications. So this is certainly a technique that could guide our practice. It's convenient and it provides real-time feedback. If you have not been using EEG, I would strongly recommend incorporating it into your practice. Of course, we're looking at electrical activity. Our goal is to get isoelectric, and at that point we've achieved a high degree of metabolic suppression. This should perhaps guide your degree of cooling. So for example, we do total arches between about 21 and 26 degrees. So if we're aiming for 26 degrees, but we have not yet achieved isoelectric on the right and left, we will perhaps further cool to get to that point. During the cooling phase, you should watch for hemispherical symmetry. And also during rewarming, if you get the return of one side and not the other, it should be cause for concern. Other techniques used to monitor cerebral protection include jugular bulb saturation. Normal values fall in between 55 to 75%. This is an indicator of cerebral oxygen extraction. The literature shows that values below 50%, you start getting neurological deficits. Other centers may incorporate the use of transcranial Doppler to measure cerebral blood flow or to detect emboli. So let's go ahead and move into the cerebral DO2 study. At our center, we use moderate hypothermia coupled with unilateral SACP. The reason we have moved this way is we believe it avoids all the disadvantages of deep hypothermic circulatory arrest, and those include vasoconstriction, coagulopathy, hyperglycemia, and we're also able to decrease our bypass duration. Some things to be aware of when using moderate hypothermia. Again, we talked about cerebral metabolism at hypothermia is still very notable. At 28 degrees, we still have 50% of our baseline metabolism. When using unilateral SACP, we need to be cognizant of the fact that we're potentially hyperperfusing the right and hypoperfusing the left. There are a number of risk factors associated with aortic arch surgery in general. 30-day mortality is around 3.2 to 4%. Incidence of stroke perhaps is between 6 and 8%. And then transient neurological disorders around 4%. Predictors of mortality at 30 days include age, reoperation, femoral cannulation, and bypass duration. There are also a number of predictors that have been explored for temporary and permanent neurological dysfunction, including the circulatory restoration, whether or not it was an emergency, whether they had coincident coronary artery disease, whether they had impaired renal dysfunction, or what their operative time was. Just to review the potential advantages of antegrade cerebral perfusion, it best mimics physiological cerebral perfusion. It provides homogeneous capillary perfusion. It extends the safe duration of circulatory arrest and allows us to use moderate hypothermia due to the increase in oxygen delivery. And then we are able to decrease our bypass duration, as we mentioned earlier. Longer bypass is bad. It can lead to adverse events such as an increase in endothelial permeability and then eventually organ dysfunction. So quickly, let's just look at some specific advantages of unilateral ACP. Again, you can convert to bilateral if you absolutely need to, but it's good to keep the procedure simple if possible. Bilateral may be more important if your arrest duration is longer, up in that 40-50 minute range. And then recently there was a meta-analysis that suggested there's really no difference between unilateral and bilateral cerebral perfusion when we're examining overall mortality and looking at permanent neurological dysfunction. Unilateral ACP at 28 degrees has been associated with good outcomes. So we went over the statistics for arch surgery in general a few slides ago. If you remember some of those figures, these are actually lower. 30-day mortality is less than 1%. Temporary neurological deficits is low at 2.3, and permanent very low, again, at 0.9. We also have an additional benefit of decreasing our length of stay in the ICU. Now, moderate hypothermia coupled with UACP is not without disadvantages. So in many cases, if you guys use this technique, you will note that sometimes you do have a notable decrease in your right and left regional saturations, or a growing differential between your right and your left that is cause for concern. And it certainly is. If you leave it untreated and it persists, it can lead to post-operative neurological complications. So what can we control when we're using this type of technique, moderate hypothermia coupled with one-sided perfusion? Well, we can control our pump flow, we can control hemoglobin, we can increase PCO2, we may have the surgeon assist us, so they may, if they have not already snared the left carotid, they could insert a left carotid cannula if absolutely necessary, or restrict flow down the right subclavian. Today, we're going to be focusing on the top two, which combined together gives us our oxygen delivery. So the purpose of this study was to determine if cerebral oxygen delivery during unilateral SACP was associated with the right or the left nadir regional saturation. And reasonable hypothesis was that lowering our delivery would result in a lower left or a lower right nadir regional saturation. This study was undertaken at the University of Colorado Hospital. It included consecutive aortic patients between the years 2013 and 2017. Our inclusion criteria included nadir bladder temperatures between 21 and 29 degrees, which corresponds to our total arch and our hemiarch procedures. Our total arches being between about 21 and 26, and then our hemiarches targeting 28. Of course, you needed circulatory arrest with unilateral SACP, and then you needed a documented nadir cerebral regional saturation. After all that, our total came up to around 106. Just a brief note on our perfusion and surgical technique. We preferentially cannulate the innominate artery if we cannot for some reason, if there's disease or if it's a redo. Perhaps we'll cannulate the axillary artery. We use a dual stage in the right atrium. We're using moderate hypothermia. We're using a modified pH stat technique, so we're not adding CO2 in. We are just reducing our sweep to very low levels. That means down to about 0.5 liters per minute in order to get that PCO2 up. And we've been pretty successful using that. We are able to get our PCO2s temperature adjusted between 30 and 40. And then, of course, on rewarming, we're using alpha stat. Our history includes a period of time where we used custodial. More recently, we are now using Del Nido. Our aortic surgeon was the first to kind of get on the Del Nido bandwagon, and then everybody else kind of followed suit. It is, provides a similar extended arrest that custodial does, but it's quicker. And if you can decrease your bypass time, then the surgeons are on board with that. So why not use it? Our unilateral SACP, our procedure is, of course, reduce flows, drain the patient out, snare the innominate. We start at 10 mils per kilo per minute, like many centers do, and then we diligently monitor our regional saturations. These are my attempts at illustrating hemiarches and total arches. Now, I didn't do the hemiarch justice here, but you can see that we are snared here at the base of the innominate, and then there is a 10 millimeter Dacron graft that is attached to our perfusion arterial line. Now, the hemiarches, the way our surgeon actually does this is he takes a tube graft and he cuts it at an angle such that it extends more into the minor portion of the aortic arch. So I don't show that too well here. There's a reason I'm not an artist. But it extends up more into here. For our total arches, if you listen to Paul's lecture yesterday, he described his dual perfusion technique. Ours is similar, but has a few differences. So this is your innominate graft, and there's also a limb coming off of the aortic arch graft. These two are wide together and connect to the same arterial line coming off of our bypass circuit. And then, of course, we are able to reperfuse early after perhaps maybe do a descending stent and then finish the distal anastomosis. And we can position the clamp here or perhaps this direction and reperfuse maybe after 20 minutes. Additional pictures of hemiarch. On the left here, we have a beveled hemiarch, and then compared to a normal ascending aorta replacement. This is an actual intraoperative picture showing where our Dacron graft attaches to the innominate artery, and then where we snare it down. During unilateral SACP, we are keeping our right radial pressures between 50 and 80 millimeters of mercury. Again, some more illustrations of the total arch replacement. My illustration on the right here, and then the actual graft with the limb coming off of it that we put a 3/8 inch connector on, which attaches right to our 3/8 inch arterial line. And remember, again, that is bifurcated such that one goes here and then one goes to the innominate artery. This is an intraoperative picture of the same technique. So you have your innominate graft up here, and then your distal perfusion branch here. So the main outcome in this study was the right and left nadir regional saturation. These were measured by the CASMET or the Somanetics monitors and recorded by our LivaNova Connect system. Our primary predictor was cerebral oxygen delivery. The way we calculated this was we took the hemoglobin immediately prior to circulatory arrest and then the blood flow during circulatory arrest using the oxygen delivery equation. As many of you, so we monitor these things real time during the non-circulatory arrest period, but during circulatory arrest, our BCARE 5 sensor, because of the low flows, cannot provide an accurate enough information for us to do this real time during circulatory arrest. Secondary predictors, we looked at demographics, bypass duration, naso and bladder temperatures, the duration of arrest, and then the mean arterial pressure during the cerebral perfusion. This table shows the patient characteristics of our sample. Our mean age was just under 60 years old. Most of our patients were men, almost 80%. The BSA was around 2.1. Euro scores were just under 10. About a quarter of our population were reoperations. Our duration was about a mean of 19 minutes. Now, I should split this up. For our hemiarches, our fastest hemiarch right now is 5 minutes. So our hemiarches range between, we have a pretty quick aortic surgeon. Our hemiarches range between the quickest being 5, so that distal anastomosis being completed and then reperfusing within 5. And then, most often we also have to have a good fellow. But most often we are in that single digit right under 10 minutes for our hemiarches, so 7 to 9 minutes. For our total arches, of course, it depends on what we're doing, but if we have a descending stent, and then we have the distal, and then we decide to do the left subclavian before reperfusing through the limb, we're up in that 20-plus minute area. Mean arterial pressures were good in the mid-60s. The hemoglobin immediately prior to circulatory arrest was also pretty good at about 10.5. Our mean oxygen delivery was about 174 milliliters of O2 per minute non-indexed. Let's go ahead and look at our univariate predictors. So significant univariate predictors of the right nadir regional saturation turned out to be the nadir nasopharyngeal temperature, the duration of bypass, and the time to circ arrest. At the bottom here, you will see some non-significant predictors, and amongst them is cerebral oxygen delivery, so it is not yet a predictor. When we look at the left, we see the same thing. Cerebral oxygen delivery is not a statistically significant univariate predictor of the left. However, there were a few significant predictors. Sex was one of them. Unilateral SACP category duration was another one of them. Nadir nasopharyngeal temperature, and then also time to circulatory arrest. In multivariate regression model, for the right side, we found that cerebral oxygen delivery, again, was not a significant independent predictor. And neither was anything else included in this model. So far, we have not really found anything that interesting. However, what you will see is that science always has a way of telling you what you're not thinking of. So when we looked at the left, we found that cerebral oxygen delivery became a statistically significant independent predictor of the left lowest nadir saturation. Also in this model, temperature became a significant predictor. So this was our first real eye-opener, and we said, okay, why? Why is cerebral oxygen delivery not a predictor of the right, but certainly a predictor of the left? We will get to that discussion in a few slides. But first, let's take a look at this figure. This figure shows the estimated blood flow increase that's required to increase the left nadir saturation by 1% at given hemoglobin levels. Now, the way we came up with this graph is we used the results from our multivariate regression model in combination with our cerebral oxygen delivery equation. So as you can see, as your hemoglobin level decreases, the amount of flow that you need to provide more of increases. So if you want to get a 1% increase in your left nadir regional saturation during moderate hyperthermia using unilateral SACP, at a hemoglobin of 7, you need about a 200 ml per minute increase in your blood flow. Now, we did this graph for a 5% increase. However, in many cases, it's not practical. Just to mention some results from that graph that's not shown here, but at the same hemoglobin level, to get a 5% increase in your left nadir regional saturation, you need almost a liter more of flow. So as you all know, you're going to hit your pressure ceiling before you ever get close to that during unilateral SACP. So now let's return to the most interesting question here. Why is cerebral oxygen delivery an independent predictor of the left and not of the right? Well, I think there are a few reasons here. One is that the right side is receiving this condition of luxurious flow, right? We are cannulated on the right side. We are dilating the cerebral vessels with pH stat. And then on the other side of this is that the flow to the left may be restricted. So if we think about the prevalence of circle of Willis variation, a lot of people have incomplete or hypoplastic circle of Willis's, and then also there is a good deal of cerebrovascular disease. So perhaps we have this condition of luxurious flow on the right in combination with a restriction of flow to the left. We also have the potential for a preferential flow and shunting, so down the right subclavian, or water shedding out the left carotid. So let's tackle each of these individually. What are potential reasons behind excess flow on the right? Well, one study suggests that normal cerebral blood flow in healthy adults who are not on bypass is around 700 milliliters per minute. If we jump to our study results, our mean flow was 1.3 liters per minute, so we are certainly providing a good deal of flow. One thing to be cognizant of is that on bypass we are diluted. So this study that reported the healthy blood flow, or the blood flow in healthy adults, they probably had higher hemoglobin levels because they were not on bypass and not diluted. So their oxygen delivery, although their flow was lower, was probably higher. When we look at pH stat, one study found that using this technique can increase blood flow by up to 191% at 26 degrees. So there is certainly good reason behind luxurious flow on the right. So let's switch gears to the left. Half of us sitting in this room right now, based on these reports, have circle of Willis variation. We either have a missing artery or a hypoplastic artery in that primary collateral system. In patients with non-cardiac ischemic stroke, this variation can be as high as 76%, so it is highly prevalent. Another study found that having small communicating arteries has potential to decrease flow to the contralateral side. So they found that arterial diameters in the circle of Willis less than 0.5 or less than 1 millimeter could lead to flow decreases. So just to remind us, here's my illustration of the circle of Willis as best as I can, reminding us of the communicating arteries and how important this system is as a primary collateral system for the brain. Again, more illustrations. We talked about how there is a high prevalence of this, potentially more than 50%. Most people have missing posterior communication. A smaller proportion have missing anterior communication. More incompleteness on the left versus the right. So the next question we have to ask ourselves is, okay, we know there's a lot of circle of Willis variation. Does that necessarily mean that it prevents perfusion to the contralateral side? And unfortunately, there's just not a lot of literature on this point. So we could say, hey, this patient has circle of Willis variation, but we don't really know if that's going to affect them clinically, if it's going to be a functional detriment. So this study suggests that perhaps circle of Willis abnormalities do not lead to poor perfusion. This study looked at 99 patients undergoing open heart surgery. They all had preoperative CTs done. A high proportion of them had incomplete circle of Willis's, about 40%, but only 1% of these patients actually had a postoperative neurological deficit. So just something to keep in mind as we talk about why. Let's see, secondary findings. So we also looked at whether you were male or female. Remember, it was significant in univariate analysis, but then lost significance in the multivariate model. We believe it was just slightly underpowered. Our sample size is mostly men. Remember, it was 80% male. So it's possible that this did have an effect on the left side, but we just were underpowered to see it. One study found that it is linked to circle of Willis variation. In 300 patients that underwent MRA imaging, they found that women most often had a complete circle of Willis. So we're looking at 28% complete versus 11% complete in men. Other secondary findings, we found again that nadir bladder temperature was an independent predictor of the left lowest saturation. Again, this is not unreasonable. Temperature has been proven to be neuroprotective. So again, at 25 degrees, which is where we do our total large cases, our metabolic rate is as high as 35% of baseline. And that potentially gives us a safe restoration of about 14 minutes. So let's jump to our study. In our study, again, 21 to 26 degrees for our total arches. Our mean circulatory restoration was 26 minutes, plus or minus 14. So we are above that safe restoration. And then also, it's not unreasonable to think that temperature is very important if contralateral perfusion is limited. So it becomes our primary mechanism of protection when we do not have adequate oxygen delivery. Limitations of this study, We could have benefited from a higher regional saturation recording rate. However, this didn't seem to prevent us from seeing statistical differences. We did not include all potential predictors that are found in the literature, such as preoperative circle of Willis evaluations, collateral perfusion assessments, such as the carotid occlusion test. But we did include previously established predictors of neurological protection, including temperature and mean arterial pressure, in our multivariate analysis. And then, of course, our study included mostly men, so we may have missed out on potentially finding a link between men and women in the circle of Willis variation. Concluding statements here. Cerebral oxygen delivery may be more important for left-sided regional saturation. And remember, this is in the context of our study. So with moderate hypothermia coupled with unilateral SACP, we talked about how the right side receives luxurious flow. We're cannulated on the right, we're using pH stat, and we're seeing high flows on that side. And then on the other side of that is the left side may be restricted. Left side may be seeing less blood flow due to preferential flow down certain vessels, maybe down the right subclavian. We know that circle Willis variation is pretty prevalent, so you can have absent or small vessels that prevent flow. And then also you could have functional abnormalities such as vascular disease and then shunting across and out that left carotid vessel. So our concluding statement here is that left-sided regional saturation can be improved by increases in flow during unilateral SACP. Sex may be linked to cerebral oxygen delivery, however, was not significant in this study. Temperature is certainly protective and may become very important when we have limited perfusion to the other side. And then when you go back to your own practices, you may consider including a functional test. So if you do preoperative CT scans, that's great, but you may not be identifying the population that's going to be at risk for restrictions to the left side based on the results in literature. So at the end of the day, why is this important to us? Again, consider a preoperative functional test so you can identify those patients at risk. We should be really diligently monitoring our regional saturations throughout the entire case, not just cerebral perfusion part of the case. If you haven't incorporated EEG, you should certainly do so. You're going to set yourself up for success if you achieve that isoelectric EEG prior to circulatory arrest. And then also, if you see a decreasing regional saturation, you should have a plan to address it. Whether that's a flow increase, a PCO2 increase, or a surgical intervention, whether you snare the left carotid, partially snare the right subclavian, cannulate the left carotid, or perhaps load the tissues with oxygen prior to circulatory arrest. So more recently, we have incorporated the oxygen pressure field theory. If you'd like to know more about that, talk to Gary Grist. He's published on that subject before, but the main principle behind that is loading the tissues with oxygen. It's about capillary exchange and PO2 tissue gradients, such that if you can prevent ischemia during the arrest time, you prevent reperfusion injury. And then finally, know your high-risk populations. Men, if they have more often an incomplete circle of Willis, those with cerebral vascular disease, or those with poor functional tests. So again, this study does not define a CDO2 threshold for poor regional saturation, but what we should instead be focusing on at this point until we have that defined is what we can modify. So modify your temperature strategy, modify your mean arterial pressure, your oxygen delivery if you're keeping track of that, perhaps change your acid-base management strategy, and then again work with your surgeon to optimize your cerebral perfusion. So with that, thank everybody for their attention. I can take questions.